So I'll speak in English because my French is actually Spanish. And yeah, it's a good accent. And I'm glad Daniel's here because he is the manager of the IMéRA WhatsApp group. So those of you who aren't in it yet and are new fellows, give your number to Daniel. I don't know how to do it. But welcome to Marseille. And I understand Karen Barkey, who's a colleague at Berkeley, is trying to come, but she's waiting on the French consulate to give her passport back so she can come. I'm Seth Holmes. I came here in September. It was an interesting time to travel from the US to Europe. It still is. And I'll give you super brief background on me and then talk mostly about my main project here, but I'm working on a few projects. So my first project that I worked on was living with indigenous Mexican immigrant farm workers and looking at the ways in which the discourses of difference and practices of hierarchy affected their bodies and bodily health, and how they were treated and conceptualized by physicians and nurses. And that's being published now in German. It just came out in Portuguese and Spanish also, and there's one article in French. And then I've been expanding that some with Syrian refugees. I did research not this past summer, but the previous summer I was in Rojava in North and East Syria and spent time in Berlin with Syrian refugees doing a sort of similar back and forth transnational research on transnational families and connections and disjunctures with refugees. I'm finishing a film that I've been working on. It's my first visual ethnography with indigenous Mexican youth in the United States. For the past 5 years, we have taken a trip for indigenous Mexican immigrant youth born in the US to meet their grandparents for the first time in their parents' home village. And as they kind of understand and navigate their identities, who they are, the languages they speak, all of that. So we're finalizing the trailer hopefully this week, and we'll put it on the website next week, and maybe I'll send it to you. Yeah. And the film, the people actually doing the filming are the youth. So it's a very participatory film. It's not professional in a different way. My more applied projects have been taking social science concepts into the medical world. So right now I'm editing a collection of articles that are taking social theory concepts and applying them to immigrant health in the British Medical Journal that I think will be published by the end of this month. And then somewhat related to that, I'm working with colleagues at the Paoli Calmettes Institute, which is the cancer hospital and cancer research center in South Marseille, would we say? And we're looking at the ways in which, recent historical experiences have led to differences in social trust and how that relates to the use of testing and the trust of politicians in COVID. So my main project here is looking at the ways in which physicians are produced as a certain kind of human subject with a certain kind of gaze that understands social difference and social inequality often as genetic, behavioral, legitimate, justified. There hasn't been very much social science or humanities research on medical training since the 80s and 90s, and there have been a lot of changes since the 80s and 90s. In the 80s and 90s, medicine was a very big topic in sociology, anthropology, kind of medicine as the training. My primary questions are, how are people training to be physicians learning to perceive and respond to social difference? How are we molded to become clinical experts and understand ourselves in that way? And how is this process different today given changing demographics, changing understandings of what global health is, and especially in the United States, but everywhere, increasing social and economic inequalities. So there's some examples, like this was published by one of the top medical publishers in the United States only a couple years ago. And it gives you different understandings of pain based on different groups. So you can see that according to this top publisher, all Arabs are Muslims, all Muslims are Arabs. It's the same category, and they all respond to pain in a specific way. You can see that all Asians, even though Asians makes up more than half of the world's population, are the same, and that they all respond to pain in a certain way. Jews are separate, Native Americans are separate, there are no whites, whites don't exist. So it's interesting. A year after this was published, I think in 2018, and a year later they apologized for it, but they published it in a peer-reviewed, textbook. I think a lot with Bourdieu and Foucault, even though in Berkeley Anthropology they're passé now. And one way I'm thinking through this project is subjectivation, the ways in which we're produced as certain kinds of subjects. I'm also thinking a lot with Bourdieu's understanding of habitus, how we are produced as embodied experts who understand and respond to inequalities in embodied ways. I'm a physician. A lot of my field notes are from my own medical training, and working with a colleague of mine, Maya Ponti. Every time we did a medical rotation during medical school, both of us are anthropologists, we interviewed each other and audio recorded our interviews talking about what was happening in the rotation, and I'm going through all those notes. And then while I was seeing patients in the hospital, in the edges of my notes on the patient that I needed to write as a doctor, for myself, I would write notes about what one of the other doctors or nurses had said that sparked, that was an interesting assumption or projection about the patient. Those are pictures of us as medical students. That's me in the bathroom, which was kind of the only place you could have any privacy while doing a medical rotation. And so far I've drafted 3 chapters. So the first chapter that I presented last semester here at IMéRA was an ethnography of an immigrant farm worker who I continue to work with, who the health system failed. Some of us physician anthropologists have been thinking about a term, structural iatrogenesis. So in medicine, iatrogenesis is when the physician or the medicine causes an illness. But we're thinking about how the structures of financing of capitalist medicine, specifically of the kind of medicine we have in the United States, causes disease and injury. And then I'm thinking the way in medical education this is talked about is the hidden curriculum, the ways in which physicians, medical students are trained to understand and interact with each other that's unofficial. We learn individualism, we learn cost savings, things like that, but there's no class on it. You just pick it up a little bit here and there in the cases that you learn. We obviously learn certain things about race, ethnicity, culture, religion, but it's not officially a course. The second chapter that I'm just finishing, that I wanted to finish by Monday but isn't quite finished, I'm using the understanding of language socialization from linguistics. So oftentimes in applied linguistics, we understand the learning of language through the framework of language acquisition, but language socialization is more about how, while we're learning a language, we're also learning that we are part of a certain group, or that we belong in a certain place within a social hierarchy, or that we're a member of a certain society or not. So I'm thinking through, as we're learning medical language, as we're learning medical jargon in medical school, what else are we learning? What else is it teaching us? And then the third chapter is looking at the ways in which learning to verbally present a patient to another doctor changes that human being into a pre-existing textbook case, and then that case acts on that patient through interventions. And then the chapters that I think I will write are looking at gendered metaphors as they relate to a certain kind of exploitation in capitalist medicine, specifically strong work, pimping, and cowboy medicine. A chapter looking at the ways in which even Maya and I, as anthropologists, talking during our rotations, the only subjects of any verb in almost all of our conversations were doctors. Nurses were acted on, patients were acted on, but doctors were always the I or the we or the they, and thinking through some of how that happens, why that happens. And then in anthropology over the last 4 years, one growing interest has been temporality, the experience of time itself. And in that chapter, I want to think through how the experience of time changes from being a medical student to an intern to a resident to an attending, and especially how that relates to capitalism and capitalist medicine. So I did my residency at the University of Pennsylvania in Philadelphia, and it's a private university, one of the Ivy Leagues, and every morning when we would come in and look at the charts of the patients we were taking care of, there were little stick-it notes that people who were paid full-time overnight would come in and read our notes and tell us that if we had written one more thing about the physical exam, they could bill more. So there are full-time people whose whole job it is to train us to write notes in a way that the hospital will get more money based on reimbursement from insurance companies. So every morning we had to then respond to all these stick-it notes about how to get the hospital more money. And then the last chapter, which I hope to draft all of this by the time I'm headed back to California. At the beginning of COVID, I interviewed all the founders of White Coats for Black Lives, a medical student organization that started at UC San Francisco, mostly medical students of color who got involved with the Black Lives Matter movement. And I interviewed the people at San Francisco General Hospital who have been calling themselves the Coalition for the Abolition of Biological Race in Medicine. And they've been working, so there's certain lab results that have race correction factors throughout the world, most of which started in the US. So there's one for kidney, which is the estimated glomerular filtration rate. If you are categorized as black by the lab, then your kidney function has to be worse in order for you to qualify for treatments. If you're categorized as white, because there's no other groups possible, you're either white or black. If you're categorized as white, your kidney function can be better and you'll qualify for treatments. There's the same correction factor for black people and the spirometer, which is lung function. And there's one other that the other one that we just are learning about now is the oximeter, the reading of oxygen, which is less functional the more melanin you have. So the darker your skin, the less likely you are to be diagnosed as having severe COVID, the less likely you are to get oxygen, the less likely you are to be offered treatments. The lighter your skin, the more likely you are to be offered treatments for the same COVID condition because the technology, the oximeter, is bad at reading through melanin. So in the conclusion, I'm writing about these groups that are pushing for change and basically hoping... the audience for this book is somewhat anthropology because I'm an anthropologist, but I think I'm writing even more for medical students, pre-medical students, medical educators, deans of medical schools and hoping that by the time they get to the end, they think, shit, this is fucked up. What do we do about it? And part of my response is not to say, listen to me, I have the equation for you to fix things, but to say, look, there are all these groups who are already doing things. Pay attention to what they're doing. So that's the plan. And I think that, oh, and then I just started working on an ERC grant. So that's the other thing that I might give up because I think I'm doing too much at once, but those are my projects.